Good evening, everyone. Hmm. Just check the audio and video. Okay, so once again, good evening, everyone. Myself, Dr. Rajul. I'm the orthodontic faculty at AIIMS. So today we are progressing as from cephalometric analysis, which we covered last week, to model analysis. So these are all part of your diagnosis and treatment planning of an orthodontic case. Okay, and they form an essential part. Model analysis is comparatively easier as compared to cephalometric analysis in terms of clinically and doing it. Okay, there are a lot of equations and formulas in this, and in this last INA exam of May only, a direct question came from Tanaka Johnson. Those who would have appeared would have remembered. They asked you to calculate value. Traditionally, I used to say that such calculation based questions are not does not come in an exam because they won't ask you to physically calculate it, but they made an exception and gave, so I should stop saying that from now onwards. Nevertheless, those who are clear with the theory were able to do it because it was a simple mathematical calculation which could be done in mind. You do not require a paper and pen. That. Okay, anyhow, we'll come to that. So beginning with model analysis. So what is a study model? So in orthodontic study, in other than other subjects speciality where we just take an alginate impression pour किया and just वो cast बन गई जो ऐसे dancing like this, we require a proper study model. Okay, it has a proper dimension, the base has a proper dimension. Okay, angulation and all that, they should be properly articulated and all that. Okay, so what are the parts of a study model? Okay, so there are two parts. One is the anatomic portion, next is the artistic portion. So anatomic portion is the one which has all the teeth, mucosa and all the anatomic structures present in it. Okay, and artistic portion is the plaster portion and the surrounding plaster model. So very easy to determine. So technically the anatomic portion should be more as compared to the artistic, and how much it is more? It is in the ratio of 3:1. Okay, so this is the first value from study model, that the ratio between anatomic to artistic portion, it should be 3:1. Just a minute. Okay, so moving ahead. So these are the various views of a study model: anteriorly, laterally, posteriorly, and the heel view. So on the posterior surface, the patient name and date are written. Full name, including the surname and date, very important in orthodontic study model, because what we do is that generally the 80% of the patients we treat are growing patients. Okay, so the date becomes very important to assess the stage of the dentition, the growth status, and what stage or what the dentition, how many teeth were present at what time. Okay, so what are the portions? So there is the maxillary and the mandibular cast. Okay, So it has a posterior border, anterior border, and a lateral border. Okay, so there, as I said, in orthodontics there are certain guidelines to make the study model. You cannot just take an impression, pour it, and be done with. Okay, it should be properly finished, polished, it should have proper dimensions. So what are the guidelines? So these guidelines were given by ABO, that is the American Board of Orthodontics, in the year 1990, and these are the ones which are followed till date. So the base of the maxillary cast is trimmed parallel to the maxillary occlusal plane. The back should be perpendicular to the midline of the palate, and the base should be 13 millimeter in thickness. Both the maxillary and the mandibular base should be 13 millimeter in thickness. Okay. Next, the total height of the maxillary and the mandibular, both the anatomic and artistic portion, should be between 3.5 to 4 centimeter, out of which 13 mm should be the artistic portion and rest is the anatomic portion. So this is how the model should be trimmed and made according to them. So as I said, the total height of each cast from the base till the occlusal surface is between 3.5 to 4 centimeter. So total in occlusion would be 3.5 plus 3.5, 7 to 7.5 centimeters. Okay, and what is the width? It is between 60 mm for the maxillary cast and 55 mm for the mandibular cast. Okay, so next dimension, the vestibular depth. So in the anterior region it should be between 5 to 6 mm, which progressively decreases as you move posteriorly. In the maxilla it is 5 mm in the posterior region and 5 to 6 in the anterior region. The heel region, or the length of the heel, is 13 mm. So this is the summary: 7 centimeter total height, okay, out of which 13 mm is the height of the artistic portion. Each maxilla and mandible 3.5 to 4 centimeter. Just remember, this was asked in your previous exam as well. It is a PYQ. Angulation with the base should be in the 90 degree. Okay, so just remember these dimensions. They are very, very important. Thickness, the breadth, the width, the height, the angulations. Okay, so traditionally I can say approximately 12, 15, 20 years back, what they used to do, you obtain a cast and you put it on a plaster mold and you have to trim it according to these dimension on the model trimmer and then finish and polish it. Okay, now the life has become much simpler. We have base formers just of this much dimension. You just have to place the poured cast inside that base and adjust it according to the height, and it should be parallel. This much you have to manage. You don't have to worry about the angulations and all that now. Okay, moving ahead. So if any of you pursue your post graduation in orthodontics, this model making and this study model making will form an important and integral part of your course. Okay, moving up ahead, the gnathostatic technique. So it was introduced by Simon in the year 1962. So it was basically relates the occlusal plane to the FH plane, that the occlusal plane of the plaster model should be parallel to the FH plane. So this Simon is the same guy who gives the Simon system of classification, the canine law, okay, of classifying malocclusion. We study in the upcoming sessions, either next week or the one after that. So beginning with the model analysis, I have broadly divided into two segments: the permanent dentation analysis and the mixed dentation analysis. Okay, so we'll be discussing the permanent dentation analysis. So first one is the Pons and Linder arch width analysis. So it tells us about the need for expansion or not. So SI stands for sum of the mesiodistal width of the maxillary incisors, and these values are taken, that is the maxillary central and lateral, and are added together. Students, just remember which in these model analysis where which incisors are taken. Like here we are taking the maxillary incisors. In the upcoming analysis somewhere it will be taken mandibular incisors. Okay, so just remember from day 1. So in Pont and Linderhardt we are taking maxillary incisors. Next we have to measure the premolar width, the interpremolar width and the intermolar width. So how do we measure that? So you have certain reference points in the maxilla. So in the anterior it is the transverse fissure of the first premolar, that is the distal pit, and in the posterior the transverse fissure, the buccal fissure of the first permanent molar, that is the mesial pit. So we determine the measured premolar and the measured molar value. Okay, so on the study model, using a divider and scale, we place the divider pointers towards the requisite points and get the measured premolar and the measured molar value. Next we determine the calculated premolar and calculated molar value. So how do we do that? From this formula. So according to Pons, it is sum of incisors into 100 divided by 80, and according to Linderhardt it is sum of incisors into 100 divided by 64. Okay, so Linderhardt later on modified it. So he changed the denominator for calculated premolar value from 80 to 85. So based on his research, he said that not 80, it should be 85. That much was the only change between these two analyses. So what do we get? Very easy to determine. If the measured one is less than the calculated, that means the arch is narrow and we need to expand it. If it's more, that means the arch is already expanded. Okay, you cannot contract an arch, it's already expanded, and it just says that there is no need for any kind of expansion in that. And how much expansion is needed in the premolar and molar region? You just need to subtract this calculated and the value and the measured value from each other, will give you the amount of discrepancy in the transverse dimension using the model analysis. Okay, so what were the drawbacks of these analysis? Very important thing and very easy to understand as well. So as Pons was a orthodontist based in France, he did a study on the French population, so the universal validity is questionable. This French population, another important MCQ. Next, the dimension or the value which he took was sum of incisors, and as we know, the mesiodistal dimensional variation in this incisor is very common. They become, sometimes they are missing, they are malformed, and malformed by what I mean is that they are peg in shape, smaller in shape, that is peg laterals. Next, third drawback. So Pons solely relied on the dimensional width of the upper incisors to assess and tell us about the transverse dimensions. He did not consider any kind of skeletal issue beneath them. So hence they become the reliability of this analysis became questionable. Okay, and as we know, lastly, that the mandibular intercanine width we cannot and should not alter through our orthodontic treatment because it is highly unstable. It will relapse. So it is said that the determining the transverse dimension of the maxillary arch, the mandibular arch form, or technically the mandibular intercanine width, should have been a more reliable treatment guideline for determining the transverse arch width of the maxillary arch. Okay, so this is the drawback and the Pons and Lindenhart's analysis. I hope I am clear until now. Very easy to understand. Next permanent dentition analysis is the Corcus analysis. So Pond told us about the transverse width and the need for expansion. Corcus tells us about the position of the upper incisors as well as the transverse dimension both. So what are the landmarks he took? So he took a point that is incision. So it is located at the incisal edge of the two maxillary incisors. So from that incisor edge, a perpendicular is drawn from the interpremolar line and the intermolar line. Okay, and similarly to Pons, he took sum of width of upper incisors. So he said that this interpremolar, the intermolar, and this width length of this line has a specific relationship between the sum of incisors. Okay, so for that specific relationship, he gave us this table. Okay, so you don't need to memorize this table. Okay, this is a specific table given in the literature. You just need to look up. So for specific sum of incisors, suppose it is 27. So according to Corcus, the arch width should be 32 in the premolar, 41.5 in the molar, and the perpendicular distance should be 16. So what it means, supposedly you get 27, and on measuring using the divider and scale, the arch width is 30 and it is 40 in the hair. That means there is a need for expansion in this region. And the perpendicular distance is also, it can be 16 or it can be 18. 18 means that the incisors are proclined. That means they need to be come back, or it comes out to be 14. That means they are retracted, they can be proclined, whatever it comes. So according to Corcus, there is a relationship between the sum of incisors with these things. Okay, so very easy to do that. So this was for the upper arch, that is the maxillary arch. So for mandibular arch, what to do is just subtract the value from 2. Why? Because the overjet is, ideal overjet is between 2 to 4 mm. So he took it at 2. So if the distance is more than the upper incisor, that means they are proclined. Okay, and if it denotes less, that means they are retroclined. And mandible value, just subtract 2 from the maxillary value and you get a mandibular distance. You cannot physically calculate it in the mandibular arch, you just need to subtract. I hope I am clear. Very easy to do. So for Pons and Lindenhardt, you need to remember the new denominator and the formula. Corcus, no need, just remember the point incision and its relationship and what does it say. Next comes Ashley-House analysis. So until now we took sum of maxillary incisors. Ashley-House took TTM, that is the total mesodistal width from first molar to the first molar. That is the distal margin of the first from one side to a distal margin of the other side, and it did not take into account second or third molar. Next it took the premolar diameter, And how do we measure the arch width? We have already told you. Okay, but here it is different. You need to measure it from buccal cusp tip of one side to the other side. Okay, so earlier we measured it from distal pit from one side to other. Here it is from buccal cusp tip from one to the other side. Next is the premolar basal arch width. Okay, so it is measured from the canine fossa. If I had to show it to you on a model, from here till here, it is the fossa. If you can palpate it in your mouth, or if you have a study model in your hand, you will say there is a depression between the root apex of the canine and the first premolar. That is the canine fossa, and it is generally located 8 mm from the CEJ, below that. So from 8 mm below this point to here, you place a divider and measure the premolar basal arch width. Okay, so just remember it is 8 mm below the crest of the canine eminence. Okay, so here again you got a measured value, and for the calculated value you have a formula. So what is the formula? It is in percentage from premolar diameter and premolar basal arch width. Okay, that means what is the inference? If the premolar basal arch width is more than the premolar diameter, that means the basal arch is sufficient to allow expansion of the premolar. Okay, so ultimately what was the drawback in Pons? He did not take into account the lower skeletal base, whether it is sufficient to allow for the expansion or not. It was not taken into account. That drawback was taken care of by Ashley Howe. Okay, so it provided a base for which a sufficient expansion could occur in the premolar region, whether there is sufficient space or not. Okay, if premolar diameter, that is the above diameter which you measure from buccal cusp tip to tip, is more, so that means it is contraindicated for expansion. So what do we need to do to correct the crowding? You need to either move the teeth distally or extract some teeth. So that is comes under methods of gaining space. And in addition to that, he gave us a guideline. So it's 37% or less you need for the extraction, 37 to 44 borderline case, and more than 44% definitely non-extraction. Okay, I hope I am clear until now. If anyone has any doubt, can ask. Otherwise, we'll move ahead towards Bolton analysis. Very easy. You all must have done in your graduation during your final year. Okay, these two, Corcus and Ashley Howe, are a bit something to understand as well. Okay, I'll move ahead. That is Bolton analysis. It was given by Bain A. Bolton. Okay, so Bolton is related to the tooth size. Okay, so very easy. Here also we need to take the sum of all the 12 teeth, 6 to 6 from left to right side in the mandible and the maxillary arch, divide them and multiply them by 100. If the ratio comes out to be greater than 91.3, indicates mandibular tooth material excess, less indicates maxillary tooth material, and how much you just need to subtract them. Very easy to that. And similarly, whether to determine it is the anterior region or the posterior, so you have a formula for the anterior 6 as well, mandibular 6 by maxillary 6 into 100, and here the value is 77.2%. just remember this 77.2 and 91.3% value. Okay, no need to explain in this as such. So whichever area tooth material is excess, that means you need to either reduce it so as to get a balance between the upper and lower arch through interproximal stripping or extraction, whichever is how much excess and how much deficiency is there, that depends on that. Okay, so this just tells us about the excess in which arch it is there. and whether it's the anterior region and posterior, it tells you about that. Okay, next is the caries analysis. Very important to know, it is for Nance and caries analysis lower, and called as arch perimeter analysis in the upper arch. Just name is different, that becomes a MCQ. करने के तरीके में, the way you do it, it's not different. So what do you require armamentarium? You require a soft brass wire to measure the arch length from the anterior to the first permanent molar using a soft brass wire. And similarly, you get a tooth material from first molar is also measured. So difference gives you the amount of discrepancy. So you taking a brass wire is like a soft pliable wire. You can mold it with your hand and you place it on the study model from first anterior of the first molar from one side to the next side, that is from 5 to 5. Okay, and you form a proper arch form, place it. Similarly, you after TTM, that is total tooth material, the discrepancy between them gives you the amount of crowding or spacing present. If there is spacing, of course the TTM will be less, arch length will be more. If there is crowding, the arch length will be less, TTM will be more. So how much difference will tell you. Here you will get to know what to do, whether to go for extraction or stripping. So if it's between 0.0 to 0 to 2.5 mm, go for proximal stripping. 2.5 to 5 mm, second premolar extraction, and greater than 5, it's first premolar extraction. Okay, so there is a chart for indicating that for mild crowding it is generally less than 2, moderate between 2 to 4 mm, severe 5 to 9 mm, and extremely severe crowding is greater than 10 mm of discrepancy is present. Next come PEC and PEC index. So we have done about proclination, transfers, Bolton deficiency, okay, crowding, need for extraction and all of that. Now to understand the need for proximal stripping. So for that you need to Sheldon Peck, and Peck gave us a formula, that is mandibular mesodistal width, sorry mandibular knee, it's mesodistal width divided by the labiolingual thickness into 100, and it is only valid for the lower incisors. See, I told you, just remember, now we have shifted from upper to lower. So it is only valid for the lower incisor. You cannot do it for every teeth. So for lower central, the ratio or the ideal value should be 88 to 92%. Okay, and lateral it is 90 to 95%. Okay, so if the ratio is more than that, you can go for proximal stripping. If it is less than that, proximal stripping is contraindicated. Okay, and what are the other things or other contraindications for IPR or proximal stripping? It is contraindicated in young patients. Why? Because they have large pulp chamber, and not more than 50% of the enamel thickness should be removed according to Sheldon and Peck. So just a quick, we have already discussed that in methods of gaining space. Those who missed that lecture can very well go on YouTube. We have that session already present there. So proximal stripping, it was introduced by Ballard and Wayman. So this is just a summary of the permanent dentation analysis which we have just discussed. For arch width, we have Pons, Linderhardt and Corpus. Tooth size and shape, Peck and Peck, Bolton and Senin and Savara. Just remember the name. No need to discuss each and everything, because sometimes they give you in match the following also, which is with which analysis. Arch perimeter tooth material discrepancy, we have caries, Nance and Fukaba. And for apical base, it is Ashley House. So for every mm of retraction of anterior teeth, space required is, so approximately 2 mm of space is required for 1 mm of retraction of anterior teeth, that is from lateral to lateral. So this completes our permanent dentation analysis. If anyone has any doubt, can write in the comment section. Otherwise, we'll move ahead with the mixed dentition analysis. Okay, so till now, as we know, permanent dentition analysis is required to assess whether we need to do expansion or not, extraction, IPR, these things. Okay, what do we need mixed dentition model analysis for? So we require them to predict the amount of future crowding, whether it will be there or not, whether there will be sufficient space. So traditionally mixed dentition analysis is done to assess whether there will be sufficient space for the eruption of permanent canines and premolars, that is 3, 4 and 5, whether C, D, E, when they are exfoliated, and as we know, their counterparts or succedaneous teeth are the permanent canines and the premolar, whether there will be sufficient space for them to erupt or not. That is the only reason for which mixed dentition analysis is done. So as I classified permanent dentition analysis, in the end I'm classifying them in the beginning only. So there are three basic approaches or three methods of classifying mixed dentition analysis. So first is based on the estimation from proportionality table. So this is a table, you need to refer them and you get the value. So this is by Moyers and Tanaka Johnston. Moyers is the most commonly used analysis, and if someone asks you most commonly clinically used, it is Tanaka Johnston, which came in your exam. Next, radiographic method is given by Hukaba's analysis, and lastly, which uses both X-rays, that is IOPs, radiograph means IOPs in this case, and prediction table. These are the Higson and Oldfather, and lastly Higson and Oldfather was modified, so it is given as modified Stanley and Kerbers. So this has the highest prediction level, or you can say the most accurate one. So most common clinically used, highest prediction level. Okay, and Tanaka Johnston is also easiest to do. You don't require any kind of X-rays or all that in Tanaka Johnston. Just how it's done, I'll tell you. Just formula, value लगाओ, and that's it. Okay, Tanaka Johnston, most clinically used, most easiest to do. Most common, Moyers. Highest prediction or most accurate, Stanley and Kerbers. So moving ahead to Moyers analysis. So before beginning the mixed dentition analysis, I'd like to tell you that before permanent dentition analysis, we sometimes took maxillary incisors, sometimes mandibular incisors, but in mixed dentition analysis we are only going to take mandibular incisors, and the reason for that is very well known. Why? Because they are first to erupt. Okay, there is less discrepancy in their sizes as compared to the maxillary incisors. Okay, so these are the two or the most common reasons by which mandible incisors are used. Okay, so permanent teeth में जो erupt होते हैं सबसे पहले mandibular incisors ही होते हैं, that's why they are used. So what is the basic premise behind Moyers analysis? So he said that there is a correlation between the size of the erupted mandibular incisors and the unerupted canines and the premolars. So what is the correlation? We'll just tell you. So what is the armamentarium required is dental cast, Bowley's gauge and probability chart. Just remember this gauge name, because in Moyers it's Bowley's gauge. Later on the gauge will change because this was recommended by the author who gave this analysis. So that becomes a question for your exam. Though they cannot ask you a probability chart based question, you don't remember the probability chart, so they ask you these kinds of questions. So what is the procedure? As usual, measure the mesodistal width of the 4 permanent incisors, add them. Okay, and using the prediction table measure their values. So okay, so from the prediction table supposedly the sum comes out to be 19.5. So he has given it separately for males and females, for maxilla and mandible. You just correlate it, go down and measure it. So accordingly, what will you get from the prediction table? You will get the estimated or the probable width of the unerupted canines and the premolars, which should be there according to the sum of the four incisors, because till now 3, 4, 5 have not erupted. Okay, so what do you have to do next? You have to, now what is present in the mixed dentition is C, D and E. So you add their mesiodistal width and get the value in mm. So one value got from, again same measured value or calculated value, one you got from here. So the discrepancy tells you whether there will be spacing in the future dentition or crowding can be expected, and accordingly you have to take up. If there will be severe crowding, you need to go for severe serial extraction or something like that can be planned. If less, then spacing is there, then you don't have to do anything. Let the dentition get erupted and exchange. So as I tell, that's why Moyers was most commonly used. You don't need to do anything, just measure it, sum of incisors, use the probability chart, compare it with the width of CDE, space less spacing, more crowd. So what were the advantages? There is no systematic or minimal, you just need to use your finger from the probability chart. Can be done with by anyone, beginners with equal. You cannot even train your assistant to do this. Very less time consuming, you don't require any equipment or radiograph. Can be done in the mouth as well, you don't even need a study model for that. And we have prediction chart for both maxilla and the mandible, different for males and females, and incisors are used. As I said, these are the first to erupt. Okay, so as this was the first Moyers analysis. Next is the Tanaka and Johnston analysis. So it is the most clinically useful, as I said. Okay, most commonly used Moyers, most clinically used Tanaka and Johnston. Here we don't need any radiographs, which was there in the previous one as well. Here you don't even need a reference tables. Okay, again the analysis is based on the sum of the lower incisors. So what Tanaka and Johnston used was 506 casts of the European patients to give their analysis. So same, measure the available arch length. Okay, basically he measured it and divided into several segments. You don't need to do that, just measure the width of CDE. Next, sum of incisors, and this is the formula. So what is the formula? Half of the width of sum of incisors plus 10.5, or half of the width of sum incisor plus 11. Give you the estimated width. 10.5 is for the mandibular, estimated width of canines and premolars in one quadrant, plus 11 estimated width in the maxilla in one quadrant. Okay, so you got the estimated width, calculated width or measured width, you get it from patient actual CDE width. Okay, so this is the example. I deliberately took it this time because it came in your exam. Okay, so here I took the arch length, complete arch length. You don't need that, just measure the width of CDE and from the formula, subtract it. If it's minus, there is deficit. If it's plus, there is spacing. Very easy to do. Just remember 10.5 for lower, 11 for uppers. So moving ahead to the third, please, if anyone has any doubt in Tanaka Johnston, do ask, because it came, a calculation based question came in last exam. Next is the Hukaba's analysis. So here, as I told you in the beginning itself, the classification, we have both study cast and radiographs. Okay, so where there is a radiograph, there is a magnification error, and that is eliminated by how? By reducing it, taking a IOPA. So as we know, IOPA is the 1:1 reproduction of the jaws. It does not have any magnification error. So this is the proportionality relationship. So actual width, we get it from the cast, apparent width from the radiograph, actual width from the cast, apparent width from the premolar. So represented by symbols. Okay, so actual width divided by apparent equals actual by apparent, just cross multiplication and very way you get it. Okay, so what question you get is slowly rely on radiograph, it's the Hukaba's analysis. Okay, does not take into account any proportionality table, anything else, no formulas. Formula is there, no proportionality tables are there. Okay, so again a PYQ. Okay, so what is the advantage? Since there is no proportionality table, there is no question of its reliability, whether it can be used for different population or not. It's just patient specific. You just need to take an accurate radiograph with proper patient positioning and no magnification error, and you can just do it very easy. Okay, moving ahead. Hickson and Oldfather analysis. So here, this is the third category which utilizes both radiographs and proportionality table. Okay, again starts with the sum of lower incisors, but here there is a catch in Hickson Oldfather. Here you measure the, so what he gave, the author traditionally gave, he measured the mesodistal width of the lower right central incisors only, not the left one. So okay, so we took the right side only. So right matlab 4:1 and 4:2 is measured, and next from the IOPA, okay, he obtained the width of the right first and second premolars from the IOPA. Okay, so what he did was, for right side and left side he gave a individual value 4:1 plus 4:1 plus 4:2. Next from IOP you get the width of 4:4 plus 4:5, and he added them. Supposedly on based on the sum you get it as 27. So using this prediction graph, just 27 ko, this line is there, this is all on the prediction graph, you don't need to try it. Just from 27 that is extended from the x-axis, point at which it intercepts, extended till the y-axis, will give you the predicted width of the sum of the canine, that is 4:3 plus 4:4 plus 4:5. So you got the predicted value, measured value, take it from the cast, that is from CDE, difference will give you the discrepancy. Okay, so when this analysis came, computational null measurements came up, so there was standard error measurements and all that were added, not required for exam. What is required is I explained it to you. So it is done separately for left and right side, and the predicted widths are added, or you can measure it separately as well. Okay, so this was the standard error, or you can say the probability or prediction chart made by them using it's a graphical method. You need to extend from the x, intersects on the y, give you the value. I hope it's clear. Okay, moving ahead. is the revised Higson and Oldfather method. Okay, so it was revised or modified by Stanley and Kerber et al. Okay, so what they did was they modified this probability chart. Okay, so then they modified using computerized data measurements from both the side. Okay, so what next, as I told you in Moyer's analysis, it was what was the calipers taken, Bowley's gauge was taken. Here they use it, just remember this name, Helios dial caliper was taken. So what was the advantage? It measured up to 0.05 mm. Okay, and hence these were the reason, because there were more computerized data technology developed by the time they came up. Okay, next rotated premolars were excluded in these analysis, so it became more accurate. This was the only difference. So based on this they gave their own graphical representation, rest everything remained the same. Okay, so what was the advantage of measurement taken on both sides? When we take measurements on both sides, you average it out. The average gives you more accurate value as compared to one single value. Okay, next comes the Nance analysis. So this is similar to the one which is done in permanent dentation. Okay, you just need to measure the width of the unerupted canine and premolars from the radiograph, and next arch length using the brass wire, space available and the space required give you the amount of discrepancy. So space available using the brass wire formed in a proper arch form placed on the study model from incisal edge from first molar to molar. Space required is from the IOPs and the erupted incisors. Difference between them gave you the amount of discrepancy. Okay. Next, it said that you need to subtract 3.4 mm and 1.8 mm. Why? To accommodate a difference. You know, if someone knows about this value, why 3.4 and 1.8, it is because the leeway space of NAN, which highlighted the mesiodistal width or difference in the mesiodistal width of the unerupted canines and premolars to that of the deciduous canines and molars. Anyhow, so again a summary of the non-radiographic and radiographic method. Some of them I have discussed. The ones which I haven't discussed are not important. Just remember the names. That will be so much will be sufficient for you to solve your MCQs. So non-radiographic comes Ballard and Wiley's, Moyer's mixed dentation, and Tanaka Johnston. Radiographic is Nance mixed dentation, Higson Oldfather, Hukaba's mixed, and a Tweed's Merrifield total space analysis. Okay, that completes our model analysis and cephalometric analysis which we completed last week. These all are really important. If someone would have given the last INI exam or had undergone the previous year question or the questions from them, would will not require me to highlight their importance. Okay, so I hope everyone, it's very clear, it's really easy to do, nothing much to, you can ponder about it and explain in this another topic. Cephalometric was comparatively more difficult and complicated with the value based scenarios and numerical data. Here it's quite less. Okay, so as I told every time value, if anyone has any doubt, they know where to reach me related to any topic of orthodontics. Any difficulty, not specifically with the one which we are discussing or the topic which is being covered, any previous topic, any other lecture, okay, I'll be happy to answer. Okay, so with that I'll close the session. Thank you for your time.